Good evening, one and all. We welcome you all back to our Scale Advanced ART Masterclass series. So it's our honor to have Sachin Dalal sir and speaking about frozen embryo transfer protocols today. Ma'am will be introducing sir shortly. And before we dive into today's session, I'd just like to inform that as most of you are aware, Scale, that is Sri Chakra Academy of Learning and Education, in association with TAPISAR, which is the Tamil Nadu and Pondicherry chapter of ISAR, has we have exclusively designed two certificate courses, which is one is genetics and infertility, and the other is reproductive immunology. The genetics and infertility is going to be a 12-week online course with weekly once classes, and reproductive immunology is going to be an 8 weeks course with weekly once classes. It is definitely going to be beneficial for whoever is participating. We already have a lot of registrations. It will be really good if you all can participate and benefit from this joint certification by Scale and TAPISAR. So for further details, you can go to scaleacademy.in, or you can contact the phone number that is given below, or you can contact either Dr. Vasundara ma'am or me. If you're interested, you can even put a message on the chat box so that we will get in touch with you. With that, the next embryology masterclass is going to be on November 6th by Dr. Sanjay Shukla sir. And the topic is going to be creating life in a dish, the critical role of embryo culture media. He's going to be speaking everything about embryo culture media. Besides this, on November 28th, we also have 20th, sorry, we are also going to have an advanced ART masterclass on immunological aspects of RIF. So I request ma'am to kindly introduce sir.
Very good evening to one and all who have joined us for this masterclass. We know it is on frozen embryo transfer protocol, and it is one of the most dynamic and evolving fields in the reproductive medicine. And we know that all of us have moved on to this frozen embryo transfer, and fresh cycles have become very minority. And we have a lot of success stories to discuss about this frozen embryo transfer outcomes. However, now from hormone replacement cycles, we have all moved on to natural or modified natural cycles in frozen embryo transfer. And we know that the cornerstone in deciding the protocol is based on the patient profile, the laboratory coordination, and also your clinical judgment. So many things, play a role in the outcome of what type of protocols you choose. And to deal with this, we are more privileged and honored to have Dr. Sachin Dalal, who has guided countless cycles with outstanding success. And he's a renowned reproductive medicine specialist amongst the, all the fertility specialists. He's well known, and he's ever willing to guide people on, when to, do progesterone. This is the value. Should I start progesterone now? If the LH is elevated, when should I consider this as a LH surge? So many, ready reckoner questions. Day to day life, sir is, sharing his expertise and, guiding us in patient success stories. So without much ado, today he is going to take us through the physiological basis of timing of frozen embryo transfer, pros and cons of different protocols, natural, modified, or program cycles, the role of monitoring of LH and progesterone, and an evidence-based update on how it can transfer our frozen embryo transfer practice. So sir is an obstetrician, gynecologist, lab surgeon, and an IVF specialist. He is affiliated to Madhu Hospital, Embryon IVF, Fortis Hospital, Jupiter Hospital Thane, Surya Hospital Chembur. He's won various awards at Monks conferences. So I would like you to please take over the session and guide us through this frozen embryo transfer protocol, sir. We welcome you for this masterclass. And we encourage all the delegates to please be as interactive as possible and gain maximum this lecture so that, we can benefit in our day-to-day practice. Thank you, sir, for accepting our invitation, being a part of this masterclass.
Thank you, Dr. Vasundara. Thank you so much for that kind introduction. And I am really thankful to Scale to invite me to share my thoughts on frozen embryo transfer, which is an excellent talk that I have tried to create, and it will help all. Just give me one moment. I'll just try to share my slides. Are the slides being seen, Dr. Vasundara?
Yes, sir.
Yes,
It's
sir.
visible. Yeah.
Okay, great. All right. So I think people are still entering the the workshop. Let us just wait for 2-3 minutes more and then start off so that in
Absolutely, sir.
case
Sure.
yeah, so it is 7:38. Let's start off by 7:42, 7:43. Yeah.
Sure, sir. Sure.
Okay. In the meanwhile, in case there are any queries, which are there, let us just address that. Anybody from the audience also has any queries? Any
Yes,
queries
sir.
regarding
Sir, I am
fertility or
Dr.
anything?
Usha. Yes, sir. Sir, I am Dr.
Hi, Dr.
Usha from
Usha.
Hyderabad.
Hi.
Hi, sir. Nice to be in your webinar. Ante, you are, I don't know how to express it. You are like one of our guide or like mentor. We see a lot of your videos. Thanks a lot for sharing your knowledge with us. So one question is like post stimulation, like immediately, like see, I have done pickup. I'll give Meprid for 10 days, and then patient will get a cycle. Will you start FET immediately, or will you give a gap? Few people give Lupride, few people give OCP. What does you follow, sir?
I'm going to be talking in that. So that's a great question. This is very relevant to today's talk. My answer is there in today's talk. So, Dr. Usha, I will be telling about
Okay,
this. Great question.
sure.
Lot of
Yeah. So, any
questions have already come to me, like whether we should do down regulation, whether we should start the FET cycle immediately after the a pickup cycle, whether we need to wait 2 cycles, or if it is a mild adenomyosis but the uterus is it's fine, other the follicles are good, should we try modified natural cycle, should we really suppress it and then go only for HRT, and what is the cutoff of your LH levels before we think it is a LH surge, whether we should trigger or not. What is the cutoff? Should we take LH 15? What if it is 18, but the follicle is good, but the echogenicity of the endometrium is still maintained? So many questions have already come to my chat box. I think after your lecture, we will be able to be having much more clarity in all this. Definitely.
yeah,
And
that
also
is the
when to
reason.
monitor the hormones, whether it is having any diurnal variation impact, when we have to do all this monitoring. So many questions. Do we have to monitor, establish ovulation, or so many questions have already there, sir, in our minds.
There are going to be amazing questions, and I'll try my level best to answer whatever I can with whatever little knowledge that I share and with that I have. So I will try to do my level best. And there is a thing that, I mean, I don't have answers to all the questions. In case I go wrong anywhere and you feel that, there is a counter thought to it, please
Yes.
share it because that is the only way that science advances.
Definitely, sir. Definitely. That's
Yeah. So 7:41, I'll just start in one more minute, and a lot of people are still joining in.
and lot of things about luteal phase support and different protocols. How do we measure the hormones? Do you take a cutoff of 10, or do we have to really monitor progesterons in natural cycles? So many things, sir.
Sir, which brand estrogen you use, sir? Nivion company?
I will. So estrogen, honestly, uh, I don't use much of estrogen. That will be a surprise. But whenever I use, it is always estradiol hemihydrate. And I use from Intas. The only reason I like that brand is that it is
Water.
dissolvable in water and I can give it vaginally. That's the only reason. Otherwise, I don't have stake in Intas company. So
I have tried
Okay.
putting the other brands and waters in front of my eyes. This Intas one, it
yes,
really, dissolves in
it
water, and
dissolves. It
it's
dissolves. It dissolves. So that is the only reason. So Intas I have actually seen dissolving, and it is this is what do you say that dispersing in hardly 2 to 3 minutes. Chalo. So I think 7:42. Let's start off.
sure, sir.
So at the outset, thank you so much, Dr. Vasundara and Scale, to have me here and share my thoughts and ideas about frozen embryo transfer. And at the outset, what is frozen embryo transfer? So it is very simple. you done IVF or ICSI. Now, people will be surprised at our center, 90% of the cycles are still IVF cycles. And I've spoken to a lot of seniors, and they still believe that in case the sperm count is good, IVF should be done, and it is ICSI that should be reserved only for the severe male factor. Otherwise, you really don't need to do ICSI. Now, when the follicles aspirated are less than 15, or if you feel that OHSS is not going to occur, then we still do a fresh embryo transfer. However, if the follicles are more than 15, or you feel that the endometrium is not good, or there might be a possibility of OHSS, then what we do is we cryopreserve the eggs. Initially, the process that was called was slow freezing. Now we all, I think, have shifted to what is called as vitrification, because with that, the embryo retrieval rate is as high as 95 to 98%. Then, when the lining is good in the subsequent cycle, we thaw that and we do a frozen embryo transfer. So, this is a very simple procedure. That is what we are going to talk about. Now, what are the indications for FET? Cryopreservation of supernumerary embryos. What do I mean by that? You have a girl whose AMH is 3, you got 17, 18, 20 oocytes, and you formed nice 5, 6 blastocysts. Now, there is no way that you can do a fresh transfer of this, because she's definitely going to land up with OHSS. So, in such cases, we freeze all the embryos and do a frozen embryo transfer in the next month. Another thing is where you feel that there are a lot of follicles on both the sides. You are seeing some fluid in the pouch of Douglas, and the patient is complaining of pain. Your serum estradiol levels are more than 2,500, 3,000. Then this is the patient where you would like to do a freezing and do a frozen embryo transfer. Also, when on the day of HCG trigger, the serum progesterone levels are more than 1.5, always do a frozen embryo transfer, because there is a asynchrony between the oocyte age and the endometrial age. When you are planning to transfer later, for whatever reason, the patient is not ready, you are not ready, you can always freeze the embryos and transfer. Or she has had 5, 6 embryos, you've done an embryo transfer, she is conceived, and we've kept the other embryos for vitrification. These are the embryos which can be transferred at a later date. Endometrium, if it's not well developed, sometimes can happen that when you've given a high dose of gonadotropin, the endometrium does not look nice. It goes out of sync. So in such cases, you might want to do a FET. And of course, for donor oocytes and donor embryos, because what actually happens is if we try to match the donor oocyte cycle or the donor cycle with the recipient cycle, it causes a lot of stress. It is better to just freeze the embryos and do a frozen embryo transfer in the subsequent cycle. So this is a small chart as to in what all cases you would be wanting to do a frozen embryo transfer. Indications for FET, again, acute, unplanned. You have had complications during the egg collection procedure. There is intraperitoneal bleeding. Or one of my friends had damage to the urethra, or you've damaged the bowel, or there is pelvic infection. You don't want to put the embryos back inside in that cycle. Or social factors. Patient is unable to do a embryo transfer now, or she does not want to have a pregnancy now. That is the case when you can do a frozen embryo transfer. Planned freezing, obviously, for pre-implantation genetic testing, that is PGTA. Not recommended for all, as in the Western countries, but definitely can be considered in women more than 40, and when there is a previous anomalous baby or previous recurrent miscarriages for the woman. Fertility preservation and recurrent implantation failure, where you might be wanting to do the ERA test. So, a few points about ERA. What is ERA? ERA stands for endometrial receptivity array. When you have a patient with recurrent implantation failure, there is something what we call as the window of implantation. That is the time which is the peak time when the embryo, when transferred, gives a pregnancy. So, in some women, especially at the extremes of ages, obese women, PCO women, there have been cases where this window of implantation is altered. And so, in such cases, you might want to do error testing. But now the recent papers are suggesting that there is not much advantage of doing ERA. And in my own clinical practice, I have done ERA for a few of my patients. It's an expensive test. And honestly, to say, we've not had great results or improvement with the ERA testing. But yes, what actually works is PGTA in cases, and of course, having nice blastocysts rather than doing a day 2 or a day 3 transfer. Now, as you see from this graph, these are the number of IVF cycles that are happening over the last almost 25, 30 years. And you can see this nice fall in the multiple pregnancy rates. And why this has occurred? Because we've all come down to transferring a single blastocyst or a double blastocyst transfer. And as seen in this graph, the fresh cycles have increased, but over the last few years, there is a tapering while the frozen cycles has increased. Similarly, as you can see in this graph over the years, the number of fresh cycles has got a plateau and is slightly coming down, while the number of frozen cycles in the same year has been going up. But what I would like everybody is to read this paper. This is an excellent paper published in 2018. It is data of 82,900, almost 83,000 cycles. It is the SART data. And what this data says, freezing of embryos in IVF cycles is beneficial only for high responders, but not for intermediate or low responders. And mind you, this is analysis of almost 83,000 cycles. So, looking at the summary of the paper, when you have 1 to 5 oocytes, look at the fresh pregnancy rates are almost double the frozen embryo rates. Miscarriage rates are lesser, live birth rates are much higher, and singleton live birth rates are much, much more higher. When you have 6 to 14 oocytes, again, fresh rates are better, miscarriage rates are lower, live birth rates are higher, and again, single live birth rates are higher. Where the picture changes is when you have more than 15 oocytes, where you would not want to do a transfer in today's time and age because of a possibility of OHSS. But here also they've got a fresh pregnancy rate of 57%, while frozen has given better. Similarly, miscarriage rates are still lower in fresh transfers, and live birth rates are slightly higher in the frozen transfer. So, what we can conclude from this slide is up to 15 oocytes, you might want to do a fresh embryo transfer, and that is something that we follow at our center. Only if it is more than 15, that is when we would do a frozen embryo transfer. And this is a very, very recent paper published in BMJ in 2025. They summarize that fresh embryo transfer may be a better choice for women with low pregnancy prognosis of a live birth from IVF compared to a freeze-all strategy. Here, what they have noted is live birth rates, clinical pregnancy rates, pregnancy losses, and cumulative live birth rates are all better in the fresh embryo transfer group compared to the frozen embryo transfer. Look at the difference. Live birth 40%, 31%, 47% clinical pregnancy, 39% clinical pregnancy, 10% lower risk of pregnancy losses, and almost 7% higher risk chances of cumulative live birth. So even after these two data, somebody is not convinced about doing a fresh embryo transfer, I can only suggest to these people that try doing a fresh embryo transfer in such patients and see for yourself. We do get pregnancies in fresh embryo transfer as well. So, how do you chart? How do you plan a frozen embryo transfer? Basically, the process begins on day 2, day 3 of the periods. Endometrial preparation is given with estrogen tablets. I use very less number of estrogen. I do a lot of letrozole cycles. Scans are done once the endometrium is more than 8. At my center, it is 8 millimeters. We start progesterone tablets, injections we don't use, do a embryo transfer after 3 to 5 days, and after 14 days, hope for a positive pregnancy test. So this is what is the standard which is followed in all cases. So this is what somebody asked, that what should be the ideal interval between IVF stimulation cycle and FET cycle, right, Dr. Vasundara? That was one question that you had. So when you have
Yeah.
done your oocyte pickup, you made the embryos, you've frozen the embryos. When you are doing transfer in the immediate next cycle versus when you are delaying it by 2 to 3 months, the pregnancy rates are better in the next cycle compared to a gap after 50 to 70 days. I have not put all the data here. You can just check this out from PubMed and you can get this paper. I would recommend going through this paper. So why first and foremost you have to decide why you want to do a frozen embryo transfer and whether you want to do a fresh embryo transfer. And once you've decided that yes, you are going for a FET, then now is the preparation for FET. Why would you want to do a FET? Because you want an accurate synchronization of the endometrium and the embryos. What is the window of implantation? Medications that we use, folic acid, I use L-methyl folate. Adjuvants, aspirin and arginine are the only two adjuvants that I use. LMWH, I don't use in fresh cycles. I use in frozen embryo cycles for all our patients. Sildenafil, in rarely I need to use sildenafil when I'm seeing the vascularity is not that great or the endometrium is thin. So aspirin, I usually use 75 to 150 milligrams depending upon body weight. Arginine 3 gram one sachet is more than sufficient, and low molecular weight heparin 40 to 60 international units. Always give a very judicious luteal phase support. I use a combination of dydrogesterone 10 milligram TDS with micronized vaginal progesterone. I don't use injectable progesterone, BD or TDS, along with enoxaparin 40 for all patients undergoing FET. Now, the important point in the FET preparation is this window of implantation, and that is the time when we do the embryo transfer. The chances of pregnancy are the highest, and the age of the embryos after thawing needs to be similar to the age of the embryo of the endometrium on the day of eating. I will be talking about this. So there are nice two papers which I found: low dose aspirin versus high dose aspirin. Low dose aspirin, this paper said that administration of low dose aspirin in FET cycles results in better pregnancy, implantation, and live birth rates without changing the uterine hemodynamics or endometrial thickness. So, simple 5 rupee tablet, if it can improve your pregnancy rates, why not? Similarly, when you're using a high dose aspirin, they've found this is a nice study where they compared two groups. So in India, we have 75 and 150. This they had in US 81 and 162. So A group was given 81, B group was given 162, started on day one of the cycle, continued till delivery. They found that a trend of lower clinical pregnancy rates and lower live birth rates in the high dose aspirin group. Hematoma formation was higher in the higher dosage group, and high dose aspirin during FET cycles may negatively impact pregnancy outcomes by increasing the miscarriage rates. And they suggested that low dose aspirin may be more beneficial. So, this is a very important take home point I think that we can follow is instead of giving 150, just give 75 for all our patients. So, what are the main endometrial preparation methods? Hormone replacement is one of the most important ones. Down regulated, stimulated. This is something that I think we all are following nowadays. Natural and modified natural. Dr. Vasundara, can you remove this line that has come on the, what do you say?
Okay, sir. I'll just check with the technical team. It's
Yeah.
not on your slide, sir.
Yeah. It's gone. It's
Yeah,
gone.
it's done.
Removed it, ma'am.
Okay, so selection of FET preparation method. Now you have armamentarium of drugs, armamentarium of protocols. What protocol would you like to do? When they are functioning ovaries, you can do all these: hormone replacement, down regulated, natural, modified natural, and stimulated. While if it is a non-functioning ovary, then we have no option but to go for a hormone replacement cycle. And this is how I think we all know about it when we will do it. And this is there is going to be a more detailed image that I'm going to be sharing in the next slides. Hormonal replacement cycle, there are two drugs that can be used: estradiol valerate, estradiol hemihydrate. Since almost 5-6 years now, I've completely shifted to estradiol hemihydrate. I use from Intas. The only advantage is that it dissolves in water and it can be given vaginally. Estradiol valerate, when you compare to estradiol hemihydrate, there have been papers which have shown that estradiol hemihydrate has a better liver safety profile compared to a estradiol valerate. So when our patient is going to be taking estrogen for almost 2 to 3 months, why not give her a documented safer molecule rather than giving a another molecule? So you would do this in anovulatory cycles, menopausal women, a failed natural cycle, and the aim is to mimic the endocrine exposure of the endometrium in the normal menstrual cycle. And this is how we all would be doing it. You can give oral and transdermal estrogen. Once the estrogen, so in this case, I will be sharing in the next cycle, in the next slide. Sorry. So yeah, the three types of preparations are available: oral, vaginal, transdermal. Vaginal, I have only used of Intas because it dissolves, though on the packet it does not mention as vaginal. Always start from day one of the menses. Why to start from day one of the menses? Because if you start from day two or day three of the menses, your FSH surge will occur and a follicular recruitment will occur. And you will be confused as to whether to track the follicle or whether to ignore the follicle. So always start from day one of the menses. So what we do is we give a strip of the tablet to the patient and tell her that the time you start seeing the periods, start it orally. What I do is I start with Endofert H orally till the time she's having periods. Once her bleeding stops, she puts it vaginally. And till now, I have never had to exceed the dose of 4 milligram. In some few thin patients, I have also used even 2 milligram and have good endometrial lining developing. If it is oral, then you might want to use 4 or sometimes you want to use 6 milligrams. Start in divided dosages. Again, there is another step up protocol where from day 1 to day 4, give 2 milligrams. From day 5 to day 8, give 4 milligrams. And from day 9 to day 12, give 6 milligrams. So this basically mimics the hormonal changes, the hormonal increase in estrogen as it occurs in the human body. Scan on day 8 and subsequently scan on day 10 or day 12. Your center cutoff can be 7 or 8. More importantly, what is important is trilaminarity. Ideally, you should do a transvaginal scan, but occasionally you might need to do a transabdominal scan. Now, I will just stop the slide share and I'm just talking about it. So, can you see my screen?
Yes, we can.
So, this is the transvaginal probe, and this is the uterus. This is the anteverted uterus. Now, when the uterus is anteverted like this, you will see nice trilaminarity. Sometimes you might have a uterus which is like this, which is a retroverted uterus. In this case, also, you will see a nice trilaminarity. But in a few patients, you will have the transvaginal probe and the uterus is like this. It's straight. How much ever you try to manipulate, you will just see something like a bright white line. You will not see a trilaminarity. Now, this is the girl in which you will tell her to do full bladder and do a trans abdominal sonography, because in only in trans abdominal sonography you will get the three lines. In transvaginal, it will be seen as one single white bright line. Am I clear?
Yes.
I will share the slides again.
Yes, sir.
All right. So, as I mentioned at our center, the ET thickness that we follow is 8 millimeter, and trilaminarity is what is important. You might have access to a Doppler. You can do Doppler studies, but we really don't do Doppler studies. The only Doppler studies that we do is to see the follicular vascularity of the oocyte in the during the follicular stimulation, but otherwise not really needed. A trilaminarity is much more important. So progesterone is initiated. I mentioned already what progesterone that we are using, and transfer is done as per embryo age. What is important if you are doing a cleavage, that is a day 3 FET, 3 days progesterone is to be given and transfer is to be done on the fourth day. If it is a blastocyst, 5 days progesterone is to be given and transfer is to be done on the sixth day. That is at 120 hours. Beta HCG to be done 10 to 12 days. So if it's a blastocyst transfer, we advise after 10 days. For day 3 transfer for after 12 to 14 days, depending upon the age of the embryo. Ideally, when you are doing a estrogen cycle, see to it that you follow 10 to 12 days of follicular phase. That means you are trying to mimic her natural follicular phase. That is what is going to give an optimum results. And in this cases, HCG trigger is not given because there is no role of HCG in a hormonal cycle. What are the advantages? It is a controlled endometrial preparation, ideal for batch IVF. Scheduling can be done to avoid weekend transfers. Cycle cancellation is low, and hardly any investigations are needed, and monitoring is needed. Disadvantages. Administration of estrogen and progesterone does not ensure complete pituitary suppression, and sometimes a follicular might get recruited or LH surge might occur in 5% of the cases. In cases of premature LH surge, progesterone elevation may occur earlier, thereby rendering the endometrium out of phase. So this will usually occur when you have used very high doses of estrogen. That is when you will find a premature LH surge occurring and progesterone is getting elevated. Risk of DVT. This is a paper which has been published by Dr. Nalini Mahajan. And recently I came to know from one of our IVF colleagues that there was a maternal mortality meeting in Mumbai, and 3 IVF specialists lost their patients to DVT in the first trimester of pregnancy because probably they were taking the high dose of estrogen for endometrial preparation, and which was continued into the first trimester of pregnancy. So, looking at the ideal duration of estrogen administration, they've noted that if you give beyond 22 to 28 days, there is significant decrease in the pregnancy rates. So, try to stop your endometrial preparation after 25 to 28 days, because more than 28 days, the results you are not going to get. So, these are the girls where you might want to change the endometrial preparation protocol, or probably want to use her PRP, or do a hysteroscopy and find out why it is a thin endometrium, why she's not responding, or if she's been taking oral estradiol valerate, try shifting to vaginal estradiol hemihydrate and see if you are getting better results. Now, we've spoken all about the estrogen cycle. Next, we will talk about the down-regulated FET cycles. The idea behind down-regulation is when you give a single dose of GnRH agonist depot. I use Lupride depot, usually half dose on day 21, because when you use full dose, sometimes the patient just does not get periods and the down regulation is very profound, especially in thin girls. So give a half dose on day 21, the preceding cycle. Give her tablet estrogen. Some people have also tried giving it on day 1 because, in case she does become pregnant, you don't want to risk that. So she's got a period. You can give a half dose of GnRH agonist depot on first day of the transfer cycle. Start with estrogen 4 to 6 milligrams. Now, in a down-regulated cycle, you will need a higher consumption of estrogen, a higher dosage of estrogen. Start daily till optimal endometrial preparation, progesterone supplementation, embryo transfer, and pregnancy testing. Advantages, the most important advantage is this down regulation prevents LH surge. Additional cost is the disadvantage, higher consumption of estrogen, side effects with GnRH agonist, and delay in resumption of menses if the FET cycle fails. This is a paper which compared HRT versus down-regulated FET cycles. There they had 1,000 cycles. Group A was given agonist depot, while Group B was given only estrogen and progesterone. And they found that live birth rates in Group A were 41% vis-a-vis for 29% in Group B. And also in women with PCOS, the pregnancy rates were almost double then the women who had not been given GnRH agonist and who were given only estrogen and progesterone. And also, more importantly, is that they found that the ectopic pregnancy rates were much more lesser in women who were given GnRH agonist depot down regulation in the previous cycle. PRP for thin endometrium. Now you have decided that you want to do estrogen cycles only because you are either scared, you don't know whether it works for a letrozole cycle or a modified natural letrozole cycle. So this is something that can be done to improve the endometrial thickness, to improve the endometrial vascularity, and to improve the endometrial receptivity. This is a very recent paper published by Dr. Nair from Delhi. They found that in patients with thin endometrium, they gave PRP on day 7, day 9, day 11. In some patients, only one dose was needed. That clinical pregnancy rates were 35% in the PRP group versus 10% in the non-PRP group. And they found that PRP significantly enhances endometrial receptivity, improves pregnancy outcomes in patients with refractory thin endometrium, and it offers a promising adjunctive treatment for patients facing repeated cycle cancellations in frozen embryo transfer. So my answer for this, if she is ovulating, do a letrozole FET and you will never ever have problem with thin endometrium in your patients of undergoing FET. Stimulated cycle. What are the stimulated cycles? Where you have given some medicine to bring about follicular recruitment, which will give a intrinsic estrogen level, which will give a nice trilaminarity, and you can go ahead with the frozen embryo transfer. So I use letrozole for all my patients. A few of my colleagues have used tamoxifen, but I have not used it. And in one patient, I have used HMG 150. REC FSH I have never used. So HMG 150, I'm going to share the live card, and it should be very interesting. So the theory behind it. When you are doing a stimulated cycle, you will find that the early pregnancy loss is significantly lower in stimulated cycle than for artificial cycles. And live birth rates are significantly more in stimulated cycles than compared to the artificial cycles. By artificial cycle, we mean HRT cycles. So, what is the protocol? I think you might want to take a screenshot of this. This is only for ovulatory or PCO women. I start on day 2, day 3. Always start on day 3, never start on day 2, because when you start on day 2, the follicular phase gets shortened. So, start on day 3. After that, the first cycle will be only letrozole 2.5 milligram. 5 milligram only if the woman's weight is more than 60 kilograms, or if she has not responded to letrozole 2.5 milligram. And I continue till follicle crosses 16 millimeters. In majority of ovulatory women with regular 28 to 30 day cycles, we need to give it for 5 to 7 days, maximum is 10 days. Only in PCO, we will have to extend it to 15 or 20 days. Once endometrial thickness is more than 8 millimeters, trigger with HCG 10,000 or RUCOG. Now we've completely shifted to RUCOG instead of HCG 10,000, and our fixed time is at night 10 o'clock or 11 o'clock. We do a serum LH levels and serum progesterone levels at the time of trigger. LH can be any level 10, 12, 14, 20, 25, 30, whatever. Progesterone should compulsory be less than 1. That means the progesterone should not have entered the system. If LH is more than 20, we trigger and we start progesterone after 24 hours. If LH is less than 15 to 20, I give HCG trigger and start progesterone after 36 hours. Start progesterone 36 hours after trigger without confirming ovulation. The patient did not come to your center for sonography. Progesterone is given for 3 days for day 3 transfers, and the FET is done on the fourth day. Progesterone is given for 5 days for blastocyst transfers, and the FET is done on day 6. Most importantly, no need to give estrogen separately either before or after FET. Data, letrozole versus hormonal FET. Letrozole was evaluated in 2,600 patients versus HRT. They found pregnancy loss to be significantly lower in letrozole FET compared to artificial cycle FET, and also live birth rates were significantly higher. Another paper, very recent paper, letrozole stimulated cycles versus HRT cycles for FAT in women with PCOS. Clinical pregnancy rates were 66% in the letrozole group compared to 53% in the HRT group. Pregnancy rates were higher in the letrozole group, and the letrozole group showed higher biochemical pregnancy and live birth rates in normal weight and normal androgen subgroups. And pregnancy outcomes were similar in the overweight and the hyperandrogenic subgroups. And last but not the least, modified HMG stimulation. So this was a nice paper where they had 5,000 odd patients, four groups, 1,800 natural, 1,600 HRT, 340 letrozole, and 1,200 modified HMG stimulated. They found that clinical pregnancy rates and the live birth rates of patients in modified HMG stimulated group were significantly higher, and abortion rates were not significantly different amongst all groups of patients. So this is the live patient of mine, which this card I had shared on the groups as well. Just a brief about this patient. She is previous to NSCS. She lost both her children in an accident. Hypertensive, diabetic, asthmatic, thyroid, obese, 40-year-old. So she was for a FET. First cycle, we started with letrozole, and she started developing some breathlessness. So we cancelled her FET, got her cardiologist evaluated, angiography done, cardiologist gave fitness for angiography, for IVF, and after a couple of months, we recruited her. Now, this is written instead of right, it is written on the left side. There was a single follicle on the right side. So this patient comes to us, hypertensive, diabetic, asthmatic, thyroid, obese, 80 kilos. Who would want to give her estrogen? At least I would not. So, previous cycle, we had given her letrozole, and after almost 15 days of letrozole, nothing had grown. So, we had to cancel the cycle. She had one antral follicle count. So in this cycle, we started her with letrozole, gave it for 10 days, and HMG 150 was given. We gave it for 5 days, scanned her, there was no growth, endometrium was thin, HMG was continued for 4 more days, and then I saw on day 13 that there was a 10 millimeter follicle. So this is what gave me hope that yes, maybe this is working. We continued her HMG 150, endometrium was thin, and after 4 days, on day 17, this follicle became 15 millimeters and endometrium became 3.3, and it showed trilaminarity. We continued our HMG 150. We have mentioned BP also here. BP was 128/90. And after 3 more days, this 15 millimeter follicle became 20 millimeter. Her endometrium went for 3.3 to 6. Still, we did not add her estrogen. We told her, come the next day. The next day, the follicle went from 20.4 to 22.3. But look at the endometrium. It jumped from 6 to 7.3. And I could see some free fluid in the endometrium. Hence, we say, okay, this is enough HMG we have given. Let us now trigger her. So we gave her HCG 10,000 at night, 11 p.m. Scanned her after 2 days. The follicle had ruptured. But in these 2 days, The endometrium jumped from 7.3 to 11.6, and mind you, we've not given her any estrogen. This is this follicle that has given her this jump. Started with Dufaston 10 milligram TDS, Emprogest 400 capsule BD, low molecular weight heparin 40 subQ daily. I also gave her Strone injection 100 milligram single dose because she had missed 1 day's tablets. Did to embryo transfer, and she came positive in the very first cycle. So this is something that can be tried, thinking out of the box, that you don't want to use estrogen. HMG stimulation can be tried. Tamoxifen, also, as I mentioned, a few of the colleagues are using tamoxifen, especially in patients with thin endometrium. Tamoxifen has showed significant increase in endometrial thickness from 6 to 7.8 in natural cycle, and from 6.2 to 8.2 in the HRT group. So some people have used tamoxifen along with HRT as well, and they found the tamoxifen protocol improves the endometrial thickness in patients after natural cycle, HRT, and ovulation induction cycle during FET. Patients with PCO show the most benefit from tamoxifen to achieve better pregnancy outcomes. I honestly have never used it. I have got excellent results with letrozole, so I follow that. Now, the last protocol that we would be talking about is the natural cycle FET. Here, this has to be a ovulating woman. You have to track that she is ovulating naturally. Otherwise, if she does not ovulate, your cycle will get cancelled. Endometrial preparation occurs by the endogenous sex steroid production by the developing follicle. Timing of ET is determined by detecting the spontaneous LH surge. Scan on day 2, day 3, there should be no corpus luteal cysts or no retention cysts. Second scan should be on day 8 to day 10 to see if the follicle is developing and look at the endometrial thickness. Once the follicle size increases beyond 14 millimeters, start checking for LH. Once LH surge is noted, see for the change in the endometrium pattern from 2 to 3 days. From type 2 to type 3. C for follicular rupture after 36 to 40 hours, add progesterone and do transfer. LH surge in urine lags up to 21 hours behind the appearance in blood. So this is something that you would be doing. You have to scan the patient more frequently, do a urinary or serum LH levels, and see for the confirmation of the corpus luteum and transfer the embryo after 5 to 6 days. But trust me, after coming from SA 2019, I started doing the natural cycle FET, but it is extremely intensive, very difficult. A lot of follow-ups are needed, a lot of blood tests are needed. The advantages is no medications are used, estrogen is avoided, and excellent endometrium develops. Disadvantage, ovulation might not occur in a regular menstrual cycle and your cycle will go. Intensive monitoring is required only in ovulatory women. More blood tests are needed. You need to do LH tests and E2 levels, and there can be a issue with progesterone estimation. So my honest suggestion is don't do a natural cycle FET, but do letrozole FET for all your patients. Now, this was another paper where they spoke about HCG administration after the endogenous LH rise, whether to be given or to not to be given. And this was a very interesting paper. Their ovulation was induced with HCG 10,000 when the mean follicle diameter was at least 17 millimeters, independent from LH values. LH elevation more than 13 IU per ml prior to HCG administration, they found, may negatively affect clinical pregnancy rates in the modified natural cycle for single euploid blastocyst transfer. They suggested that LH determination should be routinely performed during follicular monitoring, and presence of LH more than 13, HCG should be avoided. Wait for the spontaneous follicular rupture to occur, and embryo transfer should be planned. But you don't know whether the follicle is ruptured at night, follicle is ruptured in the day, because once the follicle is ruptured, already the progesterone has come into the system. So you really can't plan as to how many hours of progesterone has come in. So it is slightly difficult to do a natural cycle, and my suggestion is to stick to letrozole cycle. Now, why are we even talking about natural or modified natural or letrozole cycles? Because versus hormonal cycle or artificial cycle, because the potential influence of corpus luteum on circulating reproductive and volume regulatory hormones, angiogenic and immunoregulatory factors in pregnant women. This is a nice paper published in 2019. They found that cardiovascular function is impaired and pre-eclampsia risk is elevated in women conceiving by IVF in the absence of corpus luteum. Uh, Progesterone, plasma renin, aldosterone surged at 5 to 6 gestational weeks in more than one corpus luteum. And last but not the least, they found that compared with spontaneously conceived pregnancy, maternal milieu of IVF pregnancy is not physiologic, and specific perturbations vary according to IVF protocol and corpus luteum status. And another paper where they compared fresh versus frozen transfer for spontaneous conception. They had 24,000 fresh transfers, and they also compared almost 11 lakhs spontaneous conception. They found that compared to natural and stimulated frozen cycles, programmed frozen cycles, that is hormonal cycles, were associated with higher risk of hypertensive disorders of pregnancy, what we call as HDP, and postpartum hemorrhage. Higher risks of postpartum birth and macrosomia were detected. No significant differences in outcomes between stimulated natural cycles. And this suggested that there is a link between the absence of corpus luteum and adverse obstetric outcomes. And again, another paper where they found that ACFET, that is artificial cycle FET, was not a significant risk for clinical pregnancy rates or any other pregnancy rates, but it was a risk factor for ectopic pregnancy and live birth rate. And they found that in ACFET, there was an increased risk of hypertension and cesarean section. So, looking at this paper and doing some research, I think we all should now probably think of doing a letrozole FET or a natural cycle FET or a tamoxifen FET for your patients rather than just sticking to a hormonal cycle. And it is, of course, much more cheaper, much more safer than doing the hormonal FET. So, looking at the Cochrane study, they found that the most common modalities of FET are a natural cycle with or without HCG trigger, or endometrial preparation with hormonal cycles, or with or without luprite depot. They found four direct comparisons between two modalities, and there was insufficient evidence to support use of either one in preference of other. So that means they say that all cycles are okay, you can try whatever you want. So now this is a very important chart. How many hours of progesterone or how many days of progesterone to be given in which all cycles? So if you are giving an HCG trigger for a letrozole cycle, presume that you give an HCG trigger tonight. This is theoretical oocyte retrieval. Start progesterone day 1, day 2, day 3, and on day 4 do the day 3 transfer. On day 5 do the morula or day 4 transfer, and on day 6 will be the day 5 transfer. I don't count in hours since we are doing letrozole cycle. It usually we follow the 11 p.m., 11 a.m., and it becomes very convenient for the center as well. If you've given HRT, it is very simple. Once your endometrium thickness is more than 8 millimeters, nice trial. I mean, a straight start with progesterone, 3 days of progesterone, fourth day transfer for day 3. Similarly, 5 and 6 days for day 4 and day 5. And modified natural cycle with HCG trigger is similarly like this. And natural cycle with spontaneous LH surge, you presume that LH surge has occurred here. Start progesterone the next day immediately. Give for 3 days for a cleavage. Similarly, give for 5 days for a blastocyst transfer. And Cochrane study where they compared day 2 versus day 3 versus day 5. There was no evidence of difference identified between day 3 and day 2 embryo transfer for multiple pregnancy, miscarriage, or ectopic pregnancy per woman transferred. Obviously, blastocyst transfer is associated with higher pregnancy rates than cleavage cell, and embryo freezing rates were lower in the blastocyst transfer because only the growing embryo will go to the blastocyst. And this suggests that if 1% of the women have no embryos transferred in planned fresh cleavage stage transferred, between 2 to 4% will have no embryos transferred in the fresh blastocyst stage. What this means to say is if you didn't have day 3 embryo, obviously you will not have day 5 embryo. So only if you have had more than 10 or 12 oocytes retrieved, you have had more than 4 embryos formed, take it to day 5. If you have only 2 or 3 embryos formed, we do a fresh embryo transfer, and we do a fresh embryo transfer at cleavage stage, and it has given us pregnancy time and again. And for OD-FET cycles, where they compared cleavage versus blastocyst, they found that compared to day 3 embryos, of course, day 5 and day 6 embryos had a much higher pregnancy rates. Luteal phase support, a very judicious luteal phase support is mandatory in frozen embryo transfer because corpus luteum is deficient or not there. So you need to give a micronized vaginal progesterone 400 milligram BD or TDS, oral nitrogestrone 10 milligram TDS or QID. I usually follow 10 milligram TDS and 400 milligram BID. Some people like to use progesterone injection. It can be given the oil-based injection, Gestone 50 or 100 milligrams, water-based injection 25 or 50 milligrams up to daily. Some people like to give HCG 1500 to 5000. And last but not the least, this is something which is coming up in a big way, which I would be evaluating now. I've not yet done, honestly, but after the research for this today's talk, I will be doing it, is the GnRH agonist single dose. So what should be the ideal serum progesterone level on the day of embryo transfer? Beautiful paper by Labata et al. They divided patients into 4 groups. First group was progesterone less than 9.2. Second group 9.2 to 11.7. Third group 11.8 to 15. And fourth group was 15 to 18. They found that the implantation rates were 45% in less than 9.2, 58, 61, and 55 in more than 9.2. And also clinical pregnancy rates were much better in more than 9.2, and miscarriage rates were also noted to be lesser there in the more than 9.2 groups. So whenever you're doing a FET, ensure that on the day of progesterone, on the day of embryo transfer, at least have progesterone more than 10 and go ahead with the embryo transfer. Another paper by Nicholas Polizos, they found that low serum progesterone on the day prior to FET of euploid embryos is associated with significant reduction in the live birth rates. In their paper, they noted a low serum progesterone less than 10 one day before FET is associated with a lower pregnancy and live birth rate following FET of euploid embryos. So I just mentioned, keep a level of 10 to 12 beyond which only you would be doing a frozen embryo transfer. Now comparing vaginal progesterone gel versus injectable progesterone, nice paper, 767 cycles, where they divided into injection progesterone 100 milligram daily or vaginal progesterone gel given twice daily, plus our hydroxycaproate injection 250 milligrams once weekly. They found that live birth rate were almost the same, implantation rates were almost the same, and the clinical pregnancy rates were almost the same. So, if you don't want to inconvenience your patient by giving a daily progesterone, what you can probably do is give her just vaginal capsule or vaginal gel, and for support, give single dose of progesterone caproate, a prolotone depot, or Cornine 500 injection once a week to these patients. I do not do this. I just give a combination of nitrogestrone and micronized vaginal progesterone capsule for all our patients. This similar study. Now, GnRH agonist for luteal phase support. Beautiful paper. What they did, they gave a single dose of GnRH agonist as an add-on for luteal phase support in FET cycles. They did it on the day of FET. They found that there was a statistically significant increase there was a numerical increase in the live birth rate without reaching statistical significance. Miscarriage rates were not affected, And they suggested this potential beneficial effect was comparable between artificial and the ovulation induction cycles. So this is something what I'm going to start now is to give a single dose of lupride on the day of embryo transfer and hope for a better pregnancy. So this is another RCT where they gave a GnRH agonist during luteal phase support for FET cycles, and they found that all cycles analyzed exhibited significantly higher implantation rates, clinical pregnancy rates, and ongoing pregnancy rates in the group of patients administered with a GnRH agonist during the luteal phase compared with the control group, which did not get the GnRH agonist. And looking at the live birth rate comparison between all the four groups, that is a natural cycle, HRT cycle, and HRT cycle with GnRH agonist, and in women who were a natural cycle with spontaneous ovulation was done, clinical pregnancy rates were almost the same, and ongoing pregnancy rates were almost the same. So they suggested that they can do all types of cycles. But the recent data, we all know the safety of letrozole. Again, thin endometrium, a lot of studies are there where they have evaluated endometrium less than 8, more than 8. This is a nice paper where they compared more than 8, 7 to 7.9, 6 to 6.9, and 5. And they found that when the endometrium was thicker, more than 8, the pregnancy rates were higher. They concluded that the likelihood of achieving endometrial thickness more than 8 also decreased with the age. So in this women, you might need a higher dose of estrogen compared to younger. Okay. Another question that some patients ask is, Doctor, can I have intercourse after embryo transfer? Explain to them there can be uterine contractions, there can be pain during intercourse, possible complications can occur like infections, multiple pregnancy if she also conceives in that cycle, and God forbid if she does not conceive, then there is a big guilt that the patient can have. So we as a protocol, we don't advise intercourse after embryo transfer. Last couple of slides points to ponder. Choice of endometrial preparation should be based on details of previous cycle. Always go through the previous cycle. Proximity of the patient from the IVF center. If the patient is coming from 30 kilometers away, you cannot do a natural cycle for her. Number of visits that she can undertake, coexisting medical or surgical diseases, and last but not the least, doctor preference or experience. And as we all know, the factors affecting IVF success rate, FET success rate, the quality and age of the frozen embryo, retrieval rate, how many oocytes you got, how many number of embryos were formed, how many embryos that you transferred, endometrial preparation technique, embryo transfer technique, and last but not the least, a judicious luteal phase support. Thank you so much for a patient hearing.
Thank you so much, sir. I think you've been continuously speaking for 1 hour, but we have loads and loads of more questions. I think we should give you 1 minute to drink water if you're okay with us
Thank you
asking
so much.
many questions right away, or you need a 2 minute voice break.
Go on, go on.
Okay.
I'm good.
So, couple of things like you really highlighted that you do like, a lot of fresh embryo transfers and which should be the norm after those 2 landmark papers and your experience as well you shared. What is your typical luteal phase support? When do you start progesterone in fresh embryo transfer cycles, and what is the typical luteal phase support you do in fresh cycles, sir?
So fresh embryo transfer cycles, Dr. Vasundara, it's very easy. You did your oocyte pickup. You got less than 15 oocytes. There is no incidence of OHSs that you can anticipate. On the same day, patient will start with dydrogesterone 10 milligram TDS. So normally she starts in the evening. There are papers that have started on the second day. Some papers have started on the third day. I like to start on the same day. Micro and vaginal capsule, she will start on the second day because of that bleeding and sometimes it can occur. So you don't want to start on the same day. And simple, give for 3 days for day 3 transfer on the fourth day. And here you don't have to match. Whatever embryos are formed, just put it inside. So if you have only 1 or 2 embryos, would you be wanting to freeze those? I would not. And we all know if your serum progesterone level is less than 1.5, endometrium is nice 8 millimeters. Let the patient have a fresh embryo transfer.
So unless it is a, PPOS, we are bound to freeze the embryos.
PPOS, we have no
Then there's
option.
no other
But
option.
again, PPOS, you will only do in an anticipated hyper-responder.
Correct.
You will not be doing it in normal responder.
Right. So in antagonist protocol and agonist protocol, the fresh embryo transfer, you follow the same luteal phase support, sir?
Same. On the contrary, you would be doing a long agonist protocol for poor responders. So in long agonist protocol, you should actually do a fresh embryo transfer. And that is what is going to give you beautiful pregnancy rates. So I had a 120 kilo patient, failed previous two IVFs. They were given Indian gonadotropin, good center. I told her to lose 15-20 kilos. She lost 10, 37-year-old. We gave her Menopure 450. We got 7 or 8. I shared this on the group. We got 7 or 8 oocytes. Did IVF. Her husband's sperm count was excellent. We don't do ICSI for all. We did IVF. We got 5 embryos fertilized. On day 3, there were 4. So the best 2 embryos we transferred, and she conceived with twins. I delivered her last week.
Super.
At 36 weeks. So please go ahead.
So with regards to this agonist support, which is very interesting, and we've been doing this even for fresh embryo transfer cycles, probably on day 7, give a shot of agonist as a luteal support. The endometrium also expresses the receptors. The trophoblast also has this agonist receptors. And now in the last 3 years, I've been using this single dose of triptorelin 0.1 mg either on the day of embryo transfer, especially in trying to compare between HRT cycles and MNC cycles and see whether it is anything of great benefit. As you're saying, is a lot of promise. And then, we're evaluating the miscarriage rates and the clinical pregnancy rates. I think it is a great promise, which we should.
My next patient, I will transfer tomorrow. In this patient, I'm going to start doing giving her Lupride injection.
Yeah. So, what is the dose you're considering, sir? I use triptorelin 0.1 mg. So,
see, you use triptorelin 0.1 or you Lupride 1 milligram, same results.
Okay. Somebody has asked in the chat box, so I just thought I will just,
You feel otherwise? I mean, you feel any difference between Lupride 1 milligram and triptorelin 0.1?
No, sir. I feel it's absolutely the same. So, sir, in letrozole cycles, have you ever encountered there is some asynchrony between the follicular development dynamics versus the endometrial development? Say on day 9 or day 10, the follicle is already 18 millimeters, and then the endometrium is just 5.56. So
that will occur when you started on day 2.
Day 2.
When you start on day 3, that will usually not occur. So another thing, I get this question asked by a lot of colleagues that she is already day 10. Follicle has reached 17 millimeters, but endometrium is 5 millimeters. Should I add estrogen? I said, no, wait. You saw in that HMG cycle that I did?
Absolutely.
Just waiting for 1 day, it went from 6 to 7.2, and after trigger, after rupture, it went to 11. So wait for the hormones to act on the body. Don't jump in and add estrogen. Always you will find just waiting for, and this is not only for IVF cycle, this is for your IUI cycles, this is for your timed intercourse cycles as well. You feel that the follicle is 20 millimeters, but endometrium is 6 millimeters. Check if you have access to Doppler. Check for vascularity. If the vascularity is not that great, PSV is still 4, 5, call her the next day. In 100 out of 100, 95% of the patients, you'll find that endometrium has increased to trilaminar.
So in these things, I also do Doppler. It's a very, very useful tool to understand whether the follicle is going to have impending rupture in the next 24 hours or 12 hours based on your RI and PI. So if that is the scenario, where it's going to, the time for the endometrium to develop is going to be shorter, do you add half antagonist and kind of wait for it, or you still are okay with it to rupture and then?
Never. You're talking in FET?
Yes, sir, in FET cycles.
Never. I will never add cetrolix in FET cycles because I don't know what is the effect that cetrolix will have on the endometrium. Never. Have you used? I have never used.
Means what to do then if the follicle is almost about to rupture and the endometrium is 6 millimeters, and we do fresh transfers and antagonist protocols. So there are some school of thought where we can just use just half antagonist for some time and then probably.
Try and share experience. I have never used. Try and share experience.
Sure, sir. So you said you use low molecular weight heparin for all your cycles. So when do you typically
Yes,
start this low molecular weight, on the progesterone start day, or?
yeah, I always start on the progesterone start day. So there's a nice data that I came across that enoxaparin is having a insulin-like growth factor action, which actually helps. See, I mean, I'm not talking about recurrent pregnancy losses and other patients where you have to give it. But in normal patients also, it is an insulin-like growth factor action, which improves the implantation and the embryo acceptance rates.
Sure, so that's
So
actually a wonderful point. Maybe some immunomodulation or something that's happening.
immunomodulation is what occurs.
Yes. And
Yes.
also I have noticed, because I do Dopplers before starting progesterone. So whenever the, RA is quite high, if I add the low molecular weight heparin and do this thing, it does come down, and then, things are better. So,
Absolutely.
so you talked about progesterone exposure for 120 hours and then doing the transfer. What about day 6 or day 7 embryos? You still give 5 days of exposure and transfer, or you give one extra day of progesterone and then transfer?
One extra day. One extra day.
So if it is day 6 or day 7 embryo, you will give 6 days of exposure or progesterone transfer.
Day
That is the
7
last
embryo
option.
is usually not going to give you a pregnancy.
Okay,
That you are doing only for patient satisfaction.
that's true.
But day 6 embryo, I will usually give progesterone for 6 days and transfer on the 7th.
Okay.
And there have been papers, there's a nice paper where for day 3 embryo and day 4 embryo, they divided into 4 groups.
Blockheel's paper.
Progesterone given for 3 days and a day 3 embryo. Progesterone given for 4 days and a day 3 embryo. Progesterone given for 3 days for a day 4 embryo. Similarly, 4 and 4. And they found that progesterone given for 4 days and embryo, a day 3 embryo, gave a better pregnancy rates. So, and again, there have been a lot of papers where you do a day 5 or a day 6 transfer for a day 5 or a day 6 embryos. There is not much difference. Only my thinking is that you have frozen the embryo after, say, 120 plus 24, 144 hours.
Yeah.
Logically, give for one more day of progesterone and then do a transfer. Now, why the hurry of transferring on a day 5?
And you typically said this estradiol hemihydrate, you start, orally until the menses stops, and then you start it vaginally. So when do you stop this vaginal estradiol? At the progesterone vaginal start, you stop vaginal, or you still continue both?
Once the vaginal progesterone starts, again she takes it orally, and estradiol hemihydrate will continue till 8 to 10 weeks of pregnancy.
Okay.
I usually start tapering after 8 weeks, and at 10 weeks I stop.
So first 4 days during periods orally, then you give it vaginally, and once the vaginal progesterone starts, it becomes orally, and then 8 weeks you taper. So
Yes,
that is
orally.
a brilliant thing, sir. That is extremely good to know. Because all of us think that, oral, vaginal, and the vaginal dynamics are totally different. Like, the vaginal levels, estradiol levels are like 2000, 3000 when we measure on the day of this thing. I don't think that's going to have any impact on the...
See, no, I'll tell you my logic. You've given her vaginal progesterone, vaginal estrogen. Progesterone you will be adding after your endometrium is nice trilaminar 8 millimeters. Then what you need is estrogen just for a sustenance, just for a support. Where your oral 2 milligram BID is more than sufficient. She will never have a breakthrough building if you are scared about it.
We have a typical condition where, the patient has been through the cycle, the endometrium is very good, and then suddenly on the morning she says, I have forgotten to take the estrogen tablets for 3 days. Is it good to go? Is it okay for us to do the transfer? It's a problematic thing, because the patient, if she fails, she's going to think that, we did it.
3 days, don't do it. Maybe 1 or 2 doses, it's okay, but 3 days, don't do it.
So you said in modified natural cycles, if the LH is, above 20, then you probably don't trigger, you start the progesterone after 24 hours or whatever it is. You take the cutoff as 20, sir. So anything less than 20, you trigger the patient.
Yes. Because what happens is, once the LH surge has occurred, you don't really need to give HCG. HCG you are giving basically for LH surge. Correct? Now, in modified natural cycles, I call it letrozole FET because modified natural cycle is a very confusing term. For letrozole FET, it is so simple. You've given HCG trigger, and after 36 hours, you start the transfer. But when your LH surges occurred, has started, then in that case, you don't want to give HCG, straight start progesterone. And in our letrozole cycles, the window of implantation is very wide. So I've had patients, like we had this discussion on the group. Ashwin asked on the group. He had asked me initially, are you noting that vitrification after vitrification, thawing is taking time for the embryo to expand, and this is something that we are observing since the past few months. So a few patients where I have started progesterone at 11 a.m. in the morning, and when we've thawed at 7 or 8 o'clock in the morning, at 11 o'clock the embryo is not expanded. When we've transferred after 3 or 4 hours, after full expansion has occurred, we've got pregnancy rates. We've got pregnancy rates. So
majority of the times, night 11 o'clock you trigger, 11 a.m. will be the transfer, 11 to 12 noon will be the transfer.
always. So that, the embryologist gets time to come in the morning, thaw, wait for 3 hours, and then do a evaluation. Because we don't transfer an embryo if it is not expanded.
And what is
For
the
me, it is
transfer
very.
time when it is spontaneously the surge has happened, sir? You don't know. So you keep it in 11 to 12 even
I
then?
don't do that natural cycle I did for 5 patients. I went mad.
No, sir, not even in
Because
a modified natural cycle. Sometimes, when we see the LH, if it is like, say, 20, 21, you didn't pick it up
straight
early.
start progesterone. See what I mentioned in my slide. The progesterone should be less than 1.
Correct.
LH can be 15, 20, 25, 30, whatever. So your LH is 20, progesterone is less than 1. That means you know that progesterone has not come.
Correct.
I'm not giving HCG trigger straight after 24 hours, start with progesterone.
So, somebody is saying that we do batch IVF cycles. I'm in a remote place. Is it possible for me to do modified natural cycle or?
Cannot.
So, endometrial cavity fluid collection.
Or let me not discourage that, colleague. Try, do your own jugaad and see if you can work around it.
So endometrial cavity fluid collection in FET cycle after day 10. I think these are candidates who can benefit with letrozole FET cycle.
Of course.
So repeatedly high progesterone for HRT cycle, what should be done? What do they mean by this question? Even though downregulated with ocipils and lupride, what should be the next step?
Letrozole.
After this lecture, I think that is the take-home message. Poor responder, if progesterone is more than 1.5 in fresh cycle, do you freeze, sir?
Yes, I freeze. More than 1.5 day of trigger, freeze, yes, always.
And what is the oral progesterone you give for FET if there is no corpus luteal cyst?
Always do first on 10 milligram TDS.
And when do you stop low molecular heparin, sir? In FET
I usually stop at cardiac activity in low risk cases and by 10 to 12 weeks in high risk cases, elderly cases, previous failed cycles.
Okay,
Only if she's ANA positive or previous recurrent pregnancy loss, then I will take it up to 20 or 36 weeks of pregnancy.
And do you check progesterone levels before starting progesterone and after starting progesterone? If so, what are your cutoff levels? I'm sure it is based on the injectables or the route of administration of progesterone.
So I have shared that slide, but I'll talk here. Important levels for progesterone. Whenever you are thinking of starting progesterone should be less than 1. Only then start progesterone. On the day of trigger, progesterone should be less than 1.5. And on the day of FET, so we usually do 1 day prior to the FET because if you have a progesterone of 10 1 day prior to FET, this is the patient where I will give injectable progesterone. For FET, always progesterone should ideally be more than 12. So 1.5 and 12, 1 to 12.
Okay, sir. So suppose you're doing this HRT, FET, and you're checking the progesterone, let's say after 4 days or 5 days, 1 day before the embryo transfer, and patient is using an injectable progesterone. What will be the cutoff, sir? Sometimes injectable progesterone will be 30, 35.
No problem. Up to 60, we have transferred and got pregnancies.
Okay, sir. Is there any target level of estrogen during FET? Do we need to monitor ET level during FET cycles? I think there are a lot of...
ET mandatory, ET should be ideally more than 7 or 8 and trilaminar. And estrogen, there have been a lot of papers where they have said that more than 200 or 250 estradiol levels before starting progesterone, that is what gives a better pregnancy rates. However, I have never measured estrogen levels. I go more by sonography findings. Trilaminarity and 8 millimeters is what I would like to have.
Absolutely, because it is difficult with estrogen levels when you're using it vaginally, it's going to be very high any which ways. So,
Yes.
and this question has been beautifully explained by Sir's remarkable case of a 42-year-old. What is the maximum dose of estradiol per day we can use for thin endometrium patients, sir? I think thin endometrium, classic example. We all should understand after this lecture is that we should not do any harm. With 2 cases in Mumbai, sir told, I think we should give the benefit of modified natural cycle FET.
One, maternal mortality is growing to shake your confidence for entire year.
Right.
Trust me.
Exactly. Why is LH monitored in stimulated cycles after HCG trigger, sir? Can you explain again?
Not after HCG trigger, no
Not
role.
after HCG trigger, I think.
We are prolonging so much. The husbands and wives who are non-medicos are going to kill their gynec partners who are in this talk.
True. What could be the reason for spotting in HRT cycle with estradiol hemihydrate 6 milligram daily on day 10 or day 11 of HRT when there is no
It's
local causes, normal hysteroscopy?
She'll probably missed a few doses. That's the reason why the BTB has occurred.
GnRH Agnes single dose, sir has just spoken about it. Repeated polyp during endometrium ET cycle, I think if it is a pathological one, you need to remove it with the hysteroscopy. Otherwise, sometimes with your estrogen high dose also, it can kind of mimic like a polyp. You need to move on to MNC letrozole cycles then. Time interval between vaginal progesterone and P4 estimation on the day of FET.
Nothing like that.
I think the question will be like, since there is circadian rhythm of this progesterone spike, should we, have a specific time of measurements? Because this, I think Polizor's paper or something was measuring the progesterone in the evening at 4 o'clock where it's like, very low and, they were measuring at different time zones and telling us some confusion.
Majority of the specialty labs will stop accepting samples after 3 o'clock.
True. So most of us, as a routine, will do it in the morning. So I think.
See, like I have the luxury of doing in-house progesterone on my minividas, which at night 10 o'clock also I get the level.
So have you ever experienced this? Somebody has asked what to do if we get fluid in letrozole cycle. I don't.
Never seen in my experience till now.
Letrozole
Never
cycle
ever.
especially. I think it's a. So PRP, are you doing routinely for improving implantation or in patients with previous failed cycles despite?
Not even done once, because I always get trilaminar ET of 8 millimeters and more in all my patients. So I have never used PRP.
Sure, sir, sure.
So somebody's asked about GCSF. One of the authorities in IVF who has used the largest number of GCSF in patients of IVF. I would not take names. Everyone would be knowing that person. Brilliant IVF specialist has himself told me that GCSF does not work. So in case you want to do GCSF, you can do a combination of GCSF. It should be given subcutaneously along with PRP intrauterine.
Lot of work is going on.
I don't.
Yes, sir.
But with letrozole, I don't really need to do that. Letrozole, simple 100 rupee tablet takes care of all my problems.
Yes, sir. And also GCSF comes with its own side effects of bone pains and other things, the
Bone
dosing
pains
and
and
everything. So,
absolutely.
and you mentioned about functional ovaries. Wherever it is, you can kind of, go ahead with modified natural cycles.
One follicle, I showed you, single
Yes.
follicle, 42-year-old, I gave her HMG for 16 days.
Hats off to you, sir. That patient did so many HMGs.
No, I was shit scared. I was shit scared to give her estrogen. Who would give her estrogen? She has
Absolutely.
undergone angiography.
Absolutely. So in cases of mild endometriosis or documented endometriosis and laparoscopy or adenomyosis, but the ovaries are still, functional and good, are we, okay to, not to downregulate and do MNC cycles? Because we've had pregnancies like that. So it's not always that picture that we have to do depot downregulation in these
Not at all.
cases.
Not at all. Not at all. See, letrozole again is an anti-estrogen.
Yes, sir.
That will reduce your E2 levels. That will suppress endometriosis to an extent. So go ahead.
Thank you so much, sir. If there are many more questions, we will keep reaching out to you and troubling you at odd hours always. And you've always been so helpful to all of us. And today's masterclass was again, a brainstorming session for all of us. And thank you for all the practical inputs from your end. In our day-to-day practice, it's been very, very useful. And with great gratitude, we, sincerely thank you for, spending close to 1.5 hours on your busy day. To give us all the insights and practical points to all of us. Thank you, delegates, for being a part of this masterclass, and we will soon see you in our next masterclass, and we will definitely share the recording with you. So it is a part of every masterclass. We definitely share the recordings to all our delegates.
I just hope I didn't bore a lot of people.
Sir, absolutely not. Actually, we could go on and on, but then it's already 9 o'clock and we don't want to trouble you. We sincerely thank you for the entire 1.5 hours. Hope to see you soon, sir. Please be a part of training and teaching always. We would look forward to you.
Always.
Thank
Thank you so
you, sir.
much.
Good night, sir.
So as I say, keep spreading happiness.
Sure, sir. Definitely.
Bye.
Thank you. Thanks, Sindhuja. Thank you.
Thank you, ma'am.
Bye, Srinivasan.